Welcome to our session on intrauterine drug exposure. This is an area you'll definitely want to know well, as questions about substance exposure appear frequently on the test and in clinical practice. Let's break down what you need to know about identifying and managing these vulnerable infants. Let's start with some context. About 5.9% of pregnant women report using illicit drugs, while tobacco use is reported by 16.3% and alcohol by 10.8%. This affects roughly 400,000 to 440,000 babies annually in the US. Keep in mind that these numbers are likely underreported due to stigma and fear. The most common substances we encounter include alcohol, tobacco, marijuana, and opioids, with polysubstance use being fairly common. Understanding the scope helps us appreciate why this is a significant clinical challenge. What's important to understand is that substance use disorder isn't just about choice. It's a complex condition. The American Society of Addiction Medicine describes it using what they call the ABCs: inability to consistently abstain, impaired behavioral control, cravings, diminished recognition of problems, and dysfunctional emotional responses. Pregnancy may actually serve as a motivator for many women to seek treatment, so we often see decreased use in the third trimester. This physiological dependence is something we need to understand when caring for these mothers and babies. How do we identify substance use in pregnancy? Both ACOG and the American Medical Association recommend universal screening, asking every pregnant woman about substance use at the first visit and in each trimester. Several screening tools exist, including the CAGE-AID, CRAFT, 4Ps Plus, and TACE questionnaires. Brief intervention with referrals to community resources is essential. Remember, a non-judgmental approach is absolutely critical. Shame and stigma often prevent women from seeking help, so our attitude makes a huge difference in identification and treatment. When should we suspect substance exposure? Some key risk factors include limited or inadequate prenatal care, sexually transmitted infections, preterm labor, abruptio placentae, intrauterine growth restriction, and previous children with effects of exposure. These aren't absolute indicators, but they should raise our suspicion. The exam will often present scenarios with these risk factors and ask you to identify the likely substance or appropriate assessment tool. For biochemical screening, ACOG recommends obtaining maternal consent before testing. Urine is commonly used, but only detects recent use, several days. Meconium testing is more comprehensive, detecting exposure throughout the second and third trimesters. A 6-inch segment of umbilical cord can also be tested, with results returning more quickly than meconium. Hair testing provides an even longer detection window. Remember that false negatives are common with all these methods, so clinical assessment remains crucial. How do substances harm the developing fetus? We can categorize effects as either direct or indirect. Direct effects include teratogenic impacts, abnormal growth, alterations in neurotransmitters, and brain organization changes. Indirect effects include placental insufficiency and altered maternal nutrition. Most substances cross the placenta readily due to their small molecular weight and lipid solubility. The timing of exposure is critical. Early pregnancy exposure often leads to structural defects, while later exposure affects growth and neurodevelopment. This concept of timing appears frequently on the exam. Nicotine is actually the most commonly used substance during pregnancy, so it should be no surprise it's frequently tested on the exam. Nicotine causes vasoconstriction, reducing placental blood flow. Fetal effects include intrauterine growth restriction, hypoxia, and various malformations, including cleft lip palate. After birth, we often see jitteriness, hypertonicity, and altered respiratory function. Long-term, these children have higher rates of ADHD, lower IQ scores, and reduced lung function. For breastfeeding mothers who smoke, nicotine concentrates in breast milk at 1.5 to 3 times the plasma level. While not an absolute contraindication to breastfeeding, it can decrease milk supply and increase respiratory infections. Alcohol exposure is heavily tested on the exam. It's the most common preventable cause of birth defects in the US. The critical thing to remember is that there is absolutely no safe level of alcohol consumption during pregnancy. Not even a single drink. Timing matters tremendously. First trimester exposure is associated with the most severe effects, but damage can occur throughout pregnancy. Alcohol readily crosses the placenta and remains in amniotic fluid even after maternal blood levels have returned to zero. Stillbirth rates increase across all categories of maternal alcohol use. You'll almost certainly see a question about recognizing fetal alcohol syndrome. The classic facial features are the most reliable indicators. Thin upper lip, smooth philtrum, that's the groove between the nose and upper lip, and short palpebral fissures, eye openings. Other key findings include growth restriction and CNS abnormalities, which may be structural or functional. These facial features appear in classic cases and are something you should be able to identify from a description or photo on the exam. The long-term effects of fetal alcohol exposure are significant. FASD is among the most common identifiable causes of developmental delay and intellectual disability, with an average IQ of about 67. These children often demonstrate significant behavioral problems, learning deficits, and poor executive function. It's a lifelong condition without a cure. When answering questions about long-term outcomes, remember that FASD encompasses a spectrum of presentations, from mild to severe. Marijuana is the most commonly used illicit drug during pregnancy, and its use is increasing with legalization. THC readily crosses the placenta and blood-brain barrier. In the newborn, we may see altered neurobehaviors, tremulousness, high-pitched crying, and increased startle response. Long-term, these children may demonstrate poor impulse control and visual memory issues. There's currently no effective pharmacologic treatment available for marijuana dependence. Cognitive behavioral methods and motivational enhancement are the primary approaches. Cocaine questions focus on its mechanism of harm. It's highly vasoactive, causing significant vasoconstriction that reduces placental blood flow, leading to fetal hypoxia and growth restriction. It's associated with preterm labor, abruptio placenta, and increased meconium staining. Newborns exposed to cocaine are often irritable and tremulous, with a high-pitched cry and excessive sucking. Interestingly, neurobehavioral abnormalities often appear on day 2 or 3, rather than immediately. Near delivery, maternal cocaine use can cause transient ventricular tachycardia in the newborn, a distinctive finding you might see on the exam. Methamphetamine is a sympathomimetic agent that induces dopamine release in the CNS. Like cocaine, it causes vasoconstriction that affects fetal growth. Some research suggests it may lead to congenital brain lesions, including hemorrhage or infarction. Neonatal effects are similar to cocaine, alternating lethargy and irritability, poor sucking, and sleep disturbances. An important point: breastfeeding is contraindicated with active methamphetamine use because it concentrates in breast milk at levels 2.8 to 7.5 times higher than maternal plasma. Opioid exposure is extremely high yield for the exam. We've seen a 300% increase in NAS cases from 2000 to 2009, reflecting the broader opioid epidemic. Common opioids include heroin, methadone, buprenorphine, and prescription opioids. These substances readily cross the placenta due to their lipophilic nature. A critical concept: opioid withdrawal during pregnancy is strongly discouraged due to risks of placental abruption, preterm labor, fetal distress, and fetal loss. The treatment goal is maintenance, not detoxification. The effects of opioid exposure include intrauterine growth restriction, preterm birth, placental abruption, and an increased risk of SIDS. There's a direct effect on fetal brain development and growth. These effects aren't strongly dose-dependent, meaning higher maternal doses don't necessarily correlate with more severe neonatal effects. This is an important concept that may come up on the exam. Remember that maternal mortality from overdose is also a significant concern with these pregnancies. For treating opioid use in pregnancy, medication-assisted treatment is the standard of care. Methadone is a full mu-opioid receptor agonist that requires daily clinic visits. Buprenorphine is a partial mu agonist that can be prescribed in outpatient settings. Both medications prevent withdrawal symptoms and reduce high-risk behaviors. They're associated with decreased prematurity and improved birth weights compared to untreated opioid use. Remember that the goal is maintenance to prevent fetal stress from maternal withdrawal. This approach is well supported by evidence and frequently tested on the exam. Neonatal Abstinence Syndrome occurs in 55 to 94% of opioid-exposed infants and affects about 3.9 per 100 hospital births in the U.S. An important distinction: NAS is a physiologic withdrawal, not an addiction. These infants typically have hospital stays averaging 19 days. Interestingly, the dose of maternal opioid isn't strongly predictive of NAS severity. The development of NAS involves complex maternal, fetal, placental pharmacokinetics and the immaturity of the newborn's neurologic system. On the exam, the questions about NAS relate to onset of symptoms, what those symptoms are, and treatment options. The timing of withdrawal symptoms varies by substance. This is frequently tested. Heroin, with its short half-life, typically causes withdrawal within 24 hours of birth. Methadone withdrawal generally begins at 24 to 72 hours. Buprenorphine withdrawal tends to peak at 40 hours and is most severe at 70 hours of age. Some symptoms may present as late as 7 to 14 days after birth. Generally, the closer to delivery a mother uses, the more severe the symptoms and the greater the delay in onset. Preterm infants often show fewer withdrawal symptoms due to neurologic immaturity, another high-yield concept. What symptoms will you see with NAS? They primarily affect three systems: CNS, GI, and autonomic. CNS symptoms include tremors, irritability, hyperactive motor reflex, and seizures in 2 to 11% of cases. GI symptoms include poor feeding, vomiting, and diarrhea. Autonomic symptoms include sneezing, yawning, sweating, and mottling. You'll also see respiratory symptoms like tachypnea. Most symptoms resolve within 2 weeks, though mild signs may persist for up to 6 months. Being able to recognize this constellation of symptoms is essential for the exam. How do we assess NAS? The Finnegan Neonatal Abstinence Scoring System is most commonly used in the U.S. It includes 21 weighted items based on symptom severity. A score of 8 or higher is highly suggestive of opioid exposure and may indicate the need for pharmacologic intervention. Scoring typically occurs every 3 to 4 hours. Staff education is critical for consistency in scoring. The Lipsitz tool is another option that was recommended in the 1998 AAP statement. Eat Sleep Console is a more recent tool that is becoming popular due to its effectiveness, but may not have been integrated into the current exam content. Understanding how these scoring systems guide treatment decisions is frequently tested on the exam. The first-line approach for NAS is always non-pharmacologic care. This includes minimizing environmental stimulation, light and noise, swaddling, gentle rocking, frequent small feedings, and skin protection measures. These infants often have increased caloric needs, 150 to 250 calories per kilogram per day, due to their higher metabolic rate and GI symptoms. Supporting parent-infant interaction is crucial, as these babies can be challenging to console. These supportive measures can significantly reduce the need for pharmacologic treatment and should always be implemented first. When non-pharmacologic measures aren't sufficient, pharmacologic treatment is indicated. Morphine or methadone are the first-line medications for opioid withdrawal. The goal is to relieve severe symptoms and prevent complications like seizures and weight loss. Treatment should follow a standardized protocol for dosing and weaning. For suspected polysubstance exposure, adjunct medications like phenobarbital may be added. Clonidine is another option that decreases autonomic symptoms. The literature doesn't identify one optimal drug or regimen for NAS treatment. Protocols vary by institution. Once an infant is stable on an effective dose, weaning should begin. Typically, doses are reduced by 10 to 20% every 24 to 48 hours, based on average daily scores below 8. The weaning continues until the infant is at about 25% of the maximum dose. At that point, if the infant remains stable for 48 hours, the medication can be discontinued. Monitoring should continue for 48 to 72 hours after the final dose. If scores increase above 8 after discontinuation, a rescue dose may be needed, followed by restarting at the previous level. This methodical approach prevents rebound symptoms. There are numerous other substances that may be used during pregnancy. Benzodiazepine withdrawal is tricky because it may not appear until 2 to 3 weeks after birth, complicating diagnosis. Severe cases are typically treated with phenobarbital. Prescription opioids are an increasing cause of NAS. SSRIs can cause poor neonatal adaptation syndrome with symptoms that might be confused with withdrawal. The key takeaway is to screen based on symptoms, not just history, since maternal substance use is often underreported. What about breastfeeding? For mothers on methadone or buprenorphine maintenance therapy, breastfeeding is actually encouraged. Studies show reduced NAS severity with breastfeeding, and these medications appear in only small amounts in breast milk. However, breastfeeding is contraindicated with active illicit drug use. For nicotine users, breastfeeding isn't absolutely contraindicated, according to the AAP, though smoking can decrease milk supply. Mothers who drink alcohol should wait at least 2 hours after drinking before breastfeeding, but longer if more than one drink is consumed. Generally, the benefits of breastfeeding often outweigh the risks when mothers are in treatment and compliant. What about long-term outcomes? These vary widely and are significantly modified by the home environment. Common issues include hyperactivity, attention problems, and potential developmental delays. These children benefit from developmental follow-up and early intervention services. Parents may need ongoing support to manage behavioral challenges. Remember that the home environment can be more predictive of outcomes than the prenatal exposure itself, an important nuance when discussing prognosis. These infants have a higher readmission risk within 30 days of discharge, so discharge planning is crucial. Parents need education about persistent symptoms like irritability, poor feeding, and sleep disturbances. Supporting parent-infant bonding is essential, as these babies may be less responsive to social interaction. Home visitation programs can provide valuable support. Follow-up appointments should be scheduled within days of discharge. Connecting families with community resources helps ensure continued support after hospitalization. A non-judgmental approach is absolutely essential when working with these families. Substance-using mothers may show less positive affect and greater detachment when interacting with their infants. They may need help recognizing infant cues and behavior signals. Our role includes addressing barriers to parent-infant interaction, promoting family integrity, and preparing the family for success after discharge. Remember that substance use disorder is a medical condition, not a moral failing. To summarize what you need to know for the exam, substance exposure affects over 400,000 infants yearly. Universal screening with a non-judgmental approach is recommended. Timing of NAS varies by substance. Heroin within 24 hours, methadone 24 to 72 hours, benzodiazepines up to 2 to 3 weeks. Treatment begins with non-pharmacologic measures before moving to medications if needed, and supporting the parent-infant relationship is critical. Following standardized protocols for assessment and treatment leads to the best outcomes. Your knowledge of these concepts will be essential for both the exam and clinical practice. A 2-day-old term infant born to a mother on methadone maintenance therapy begins demonstrating irritability, high-pitched crying, increased muscle tone, and poor feeding. When would you expect these symptoms to have first appeared? 24 to 48 hours after birth, 48 to 72 hours after birth, 72 to 96 hours after birth. The correct choice is 24 to 48 hours after birth. This question is testing your knowledge of timing of withdrawal symptoms based on specific maternal substances. This is correct because methadone withdrawal typically begins at 24 to 72 hours after birth, with many cases starting in the 24 to 48 hour range. The longer half-life of methadone, compared to heroin, explains this delayed onset. 48 to 72 hours after birth is incorrect because while some methadone-exposed infants may present in this time frame, The symptoms described are already present at day 2, 48 hours, indicating they began earlier. 72 to 96 hours after birth is incorrect because this is too late for typical methadone withdrawal onset, which rarely begins after 72 hours. A neonate is admitted to the NICU with a Finnegan score of 12. The most appropriate first-line pharmacologic treatment would be clonidine, morphine, phenobarbital. The correct choice is morphine. This question is testing your knowledge of first-line pharmacologic treatment for neonatal abstinence syndrome. This is correct because morphine is considered first-line therapy for opioid withdrawal in neonates. It treats withdrawal symptoms by binding the same receptors as the original opioid. Clonidine is incorrect because while it can be used for NAS, it's typically used as an adjunctive therapy rather than first-line treatment. Phenobarbital is incorrect because it's generally used as an adjunct for polysubstance exposure or when the primary agent isn't controlling symptoms adequately, not as first-line therapy. A term infant is born with a thin upper lip, smooth philtrum, and short palpebral fissures. These findings most strongly suggest maternal use of alcohol, cocaine, nicotine. The correct choice is alcohol. This question is testing your ability to recognize the characteristic facial features of fetal alcohol syndrome. This is correct because the facial features described, thin upper lip, smooth philtrum, and short palpebral fissures, are the classic dysmorphic features of fetal alcohol syndrome. Cocaine is incorrect because while it can cause growth restriction, it doesn't typically cause the specific facial features described. Nicotine is incorrect because maternal smoking is associated with intrauterine growth restriction, but not the distinctive facial features listed in the question. When weaning an infant from morphine treatment for NAS, the recommended approach is to decrease by 10 to 20% of maximum dose every 24 to 48 hours. Decrease dosing interval first, then decrease dose amount. Discontinue abruptly once Finnegan scores are below 8. The correct choice is decrease by 10 to 20% of maximum dose every 24 to 48 hours. This question is testing your knowledge of appropriate medication weaning protocols for NAS treatment. This is correct because the recommended approach is to gradually reduce the morphine dose by 10 to 20% every 24 to 48 hours as long as Finnegan scores remain stable. Decrease dosing interval first, then decrease dose amount is incorrect because morphine weaning focuses on dose reduction rather than interval changes. Discontinue abruptly once Finnegan scores are below 8 is incorrect because abrupt discontinuation risks rebound withdrawal symptoms. Medication should be weaned to approximately 25% of the maximum dose before. A neonate with NAS demonstrates irritability, poor feeding, and disturbed sleep. Which non-pharmacologic intervention should be implemented first? Frequent, small-volume feedings, pharmacologic treatment with morphine, stimulation with bright lights and sounds. The correct choice is frequent, small-volume feedings. This question is testing your knowledge of appropriate non-pharmacologic interventions for NAS. This is correct because frequent, small-volume feedings address poor feeding and provide comfort, which is an appropriate first-line non-pharmacologic intervention. Pharmacologic treatment with morphine is incorrect because non-pharmacologic interventions should be attempted before moving to medication therapy. Stimulation with bright lights and sounds is incorrect because environmental stimulation should actually be minimized for infants with NAS, as they are often hypersensitive to stimuli and become more irritable with increased stimulation.